This interdisciplinary house calls team became a reality. Last February, I was interviewed by Andy Barry, who's a CBC radio host in Toronto, a very strong supporter of this whole concept of caring for frail seniors in the community. He held a screening of house calls now not quite 2 years ago, followed by a town hall discussion, and created a series of radio programs on the issue. And we spoke on air about how much more effective someone like myself could be if I were supported by an interdisciplinary team. Because until recently, I was very much a one-man show. And that's not really a sustainable way of working. And later that day, I received 2 emails from the CEOs of 2 large not-for-profit home care provider agencies, basically saying, how can we help? We'd like to integrate an OT into your practice. And the other CEO said, think about how one of our nurses could help you. So I met individually with these providers, and then we met collectively last April. And within 10 minutes, we had it all mapped out, and they said, well, we're going to go back to our boards and get the approval, and they did, and we met again. And we looked for a researcher, and there we had a small interdisciplinary team with an occupational therapist 2 days a week provided by CODA, a social worker 2 days a week provided by SPRINT, which stands for Senior People's Resources in North Toronto. It's a small community support agency, and a nurse provided by VHA Home Health Care. And we actually started working together in January. We're sort of in the throes of becoming operational, and we're struggling now with creating a common computerized patient record, and we're almost ready to go live with that. And what's important is the resources for this initiative were actually donated by not-for-profit agencies. This was not something that was part of the Aging at Home strategy. This actually predates the announcement of the Aging at Home strategy. And we realized that this team will not be sustainable without long-term funding. The people who came forward to donate the manpower have done so with a 2-year time limit. And we found a research partner who's studying the implementation and the outcomes of this endeavor. And here we are, just in September, signing the Memorandum of Understanding with Carol Annette, the CEO of VHA, and Trish Barbado, the CEO of CODA, and Jane Moore, the Executive Director of SPRINT. And Sheila Naismith is our research partner. She's in the Faculty of Social Work at the University of Toronto. So this is a collaborative partnership model that integrates everyone's capabilities and talents, and we're already seeing with the patients that we're caring for together that the whole is much greater than the sum of the parts. And we can leverage scarce physician human resources by alternating follow-up visits between the physician and other team members. And we believe this is a rich environment for teaching, research, and program development. And we mustn't forget in the community that personal support workers are the front line of care. They often have the most frequent contact with their clients, and they can serve a very important role, and that is to be the eyes and ears of the interdisciplinary team. When something goes wrong, they can call. There are other models. There's a very well-established group in New York City, and about a year and a half ago, I had the privilege of spending a day doing home visits in Harlem and East Harlem with one of the physicians in this group, and it's the Mount Sinai Visiting Doctors Program, and they're the largest academic home visit program in the US. In the United States, physicians like me do exist, and it's partly a consequence of, in the 90s, the Medicare fee for making a house call on a housebound senior went way up. So low-income seniors in New York City have access to home-based care. And this team provides multidisciplinary primary care to over 1,000 homebound seniors per year throughout Manhattan. And they have 6 full-time equivalent physicians. There are actually 12 doctors. Some are full-time, some are part-time. And they have 1 nurse practitioner and 2 social workers. And there's actually an American Academy of Home Care Physicians. Do you know how many full-time home care physicians there are in Canada? Anybody want to guess? There are 2. There's 1 in Victoria and there's 1 in Ontario. And I find that statistic to be frightening. Another approach is to bring seniors to the services. And the PACE programs in the United States, Program for All-Inclusive Care of the Elderly, the most famous is the On-Lock program in San Francisco, and it supports community dwelling nursing home eligible seniors. So in order to be enrolled in the program, you have to be nursing home eligible. And they bring seniors to a day health center and provide care and all kinds of social supports through that model. So they have a school bus that picks people up and takes them home. Oops. Edmonton has a similar program, CHOICE, Comprehensive Home Option of Integrated Care for the Elderly. And it's a coordinated care program which works to keep older people healthy and living at home and provides a full range of medical, social, and support services, again, using a day center, which also involves medical monitoring and treatment, medication dispensing, rehabilitation services, transportation, and in addition, they provide in-home personal care assistance. So what do all of these approaches have in common? They support older adults to live independently in the community for as long as possible. They reduce strain on the healthcare system. They reduce crisis emergency room visits and hospital admissions. That's a huge problem in Toronto, and I'm sure it's a huge problem here as well. It decreases the need for institutionalization, and it improves the quality of life for patients and families, and provides respite for caregivers. And most importantly, these approaches are highly preventative. So why don't physicians in Canada make house calls? Our healthcare delivery and training are highly centralized. I was trained in a general large tertiary referral hospital. I never made a house call as a medical student. So the delivery of primary care has evolved into a largely office-based model. There's a lack of training and exposure to home-based care. We need more role models and mentors. And under fee-for-service, it's simply not really very viable. You know, when you do work in a piecework system, which is what fee-for-service essentially is, do something that's A, more time-consuming, and B, requires travel, and you have a business case that you can't get anybody to follow, which is partly why there are 2 of us in the country. So we need a care of the elderly alternative funding plan or some form of family health team on wheels. And actually in Ontario, there is something happening, which I'll allude to in a minute. So incentives, training, and supports are desperately needed for family physicians. And if you think, if every family doctor in Ontario began caring for only 5 more, for some of them it would be 5, total housebound seniors, you know, we'd very quickly have tens of thousands of frail seniors receiving proper ongoing care. That would have a huge impact system-wide. Because replicating people like me may not be a system-wide solution. But a handful of home-based geriatric primary care physicians can train hundreds of family medicine residents, nurses, occupational therapists, social workers. We can plant the seeds of system-wide solution through a handful of people like myself. And we have to go back to the visiting nurse of the early 90s, the function that we lost. I remember the VON and the public health nurse that actually went and did ongoing monitoring of frail housebound seniors. That's a very powerful model, and we need to go back to it. And we can bridge the gap between the office and the home.